Good morning, ladies and gentlemen. It's a pleasure for me to talk to you today here about MRI in pulmonary arterial hypertension. So if we're talking about MRI in pulmonary arterial hypertension, I try to start with a concept that we would say we need an examination that gives us the right diagnosis in an unclear case and also gives us prognostic factors as well as some data that can be used for follow-up. So if we want to differentiate all these that we have heard before, we have to look what available technology we have in MR, what we could do. I will also pick the application example, again talking about the differentiating PAH and CDPH. And finally, I may not let you go from here without having at least one idea of a protocol suggestion. So, as we've heard before, we are talking about the lung and the heart and morphology and function of both. So if we look on lung morphology, this is usually the point where we'd say, well, this is probably where MR is probably the weakest. So the lung morphology changes. We can all see these on MRI. Say we have right atrial and ventricular dilatation, enlargement of the veins. We have a peripherally attenuated pulmonary vessels and enlargement of the inferior vena cava. Is this really an easy task for MRI? So if we look what is around on MRIs, we have this is the collection of all the sequences that are around and that have been used and evaluated to a different degree. So if we just run through them and have a look at what would be the most useful maybe for our case in this workup of pulmonary arterial hypertension. Of course, we have fast breath hold T2 weighted images with half Fourier acquisition to even accelerate the image. You can use parallel imaging and you get beautiful images like this. For example, this is just an infiltrate of the segment 6 of the right lower lung lobe, where we could see it nicely on two different ways of two different examples of this HASTE or half Fourier single shot TSE imaging. In pulmonary arterial hypertension, you can of course see the enlarged central pulmonary arteries, you see the peripherally attenuated vessels, and this gives you just an idea of the quality that can be reached with these images in a patient. If we want to have a better look on the mediastinum, on the chest wall, on lymph nodes, we can use again a single shot, as a multiple single shot breath hold technique with a higher spatial resolution. It's again fast spin echo, and that would show you a bit more about airways, nodules, and masses. For example, these are the images that we can have in a patient with cystic fibrosis. We can see some consolidation, we can see peripherally mucus plugging, and even the peripheral missing vascularization in this patient. And again, we can, of course, see everything that we want to see about the large central pulmonary arteries. Finally, we can add, without making the examination much longer, some functional information. These sequences have been around for quite some time and evaluated, maybe best of all what I've shown so far, in free breathing. So this is a very fast single-shot examination that goes one slice after another, always with an 80% overlap. We do 128 slices, one after another, just running through. The patient breathes freely. You need no ECG triggering for this. This just runs through and is therefore very robust because you do not need any cooperation of the patient. It has been evaluated in large numbers on pulmonary embolism. For example, if you take these sequences, you can nicely see the embolized material, for example, in this lower lung lobe artery. It has been proven with very high sensitivity and specificity, and of course it also works in pulmonary hypertension, so we get here a very rough idea about how the patient breathes, his breathing mechanics as well. We can already see that there's a significant dilatation of the right ventricle, and of course of the central pulmonary veins. And if we do this in 3 planes, we already get a very good idea about what is going on in this patient. So of course we have to talk about MRI angiography. We take this high resolution, one breath hold, high spatial resolution angiogram. We have seen beautiful examples already during the previous talks. And this is what would be realistic. Sometimes it turns not that bad. This is just a patient from last week. At least we see the enlarged pulmonary vessels, and we can see, of course, see clots and everything. And if we just run through the images of this arteriogram on the right-hand side, it gives you a realistic idea of what we could achieve. Press button, of course. And finally, we have to talk about perfusion. When we take serial 3D data sets acquired every 1 or 2 seconds and run this through and give the contrast injection, then we get this sort of type of 4D imaging where we get a beautiful perfusion image. In this case, it's an acute pulmonary embolism, and we can nicely see that there, of course, there are areas of a lower perfusion with this gadolinium contrast enhancement. And on the right side, we see an image, a single image from the peak perfusion series of an PAH patient. No CTPH, PAH, where we see a relatively homogeneous perfusion of the lung. So, and finally, we cannot stop without having at least some post-contrast images, again in breath hold techniques. So in a single breath hold, you can acquire this sort of image, and you can, of course, nicely see that we get a very good idea about the central arteries and the lung itself. So we get images like this. We can also see some slide atelectasis here. And of course, we can do all the measurements, all that we have seen for CT before, we can do in these vessels as well. And again, we have this 29 millimeter diameter number where we have a sensitivity and specificity of approximately 90% for pulmonary hypertension. And if we associate it with segmal artery to bronchus ratio, we can also see this on the MR images. We can get very specific just from the lung morphology. Well, we have seen these images, and we can, of course, say a lot about the vessels, but you may argue that this is less sensitive to lung fine structure. In particular, if you look at these two conditions of pulmonary vaso-occlusive disease or pulmonary capillary hemangiomatoses, which have a relatively subtle, more or less subtle changes in the lung parenchyma, you would have to have a closer look on what really happens, how does this present. And of course, this may end up in a catastrophe giving prostanoids. It would be important to say if we can sort of see these on MR. Always having the idea in mind, we want to take MR as a single examination, working up a completely unclear patient. So of course, it may be more expensive than CT, depending on the setting. And of course, what we also have an argument that you will frequently find is that non-experienced teams might hesitate to use and trust MR, at least as a single examination. So looking at the lung fine structure, I can just touch this briefly in this talk, but I can show you, for example, an example of sarcoidosis. We have the CT scans here in below. These are beautiful images that I got from Johnny Rochung in National Jewish in Denver. And these are the contrast-enhanced MR scans of the same patient, and you can, of course, get a rough idea about the reticulonodular pattern in this patient with sarcoidosis, and you can definitely see that there is something up in the lung parenchyma, and you can that interstitial lung disease that is that significant that it causes pulmonary hypertension. You will always see on MR. We can trust it. It's a bit like in X-ray. And of course, you could further evaluate different, for example, in this case of idiopathic pulmonary fibrosis. You see all that you know from CT in a bit lower spatial resolution, but you can definitely see a lot on lung fine structures. So this is not that weak a point. Maybe you may argue, well, emphysema means loss of lung structure, and the lung is already almost black on MR. Would you be able to see emphysema? Well, not directly. We can see it indirectly by the perfusion part of the examination. Of course, we can nicely see, here you would say, well, this is a non-contrast enhanced and a contrast enhanced scan. Already in the contrast enhanced scan, you see that here's some parenchyma missing. But if you look on the perfusion part of it, or if you do a subtraction in the maximum phase, you would also get an idea about emphysema, and this was nicely evaluated in a work of Yulia Zaporoshka in 2007, presented European Journal of Radiology, where she compared CT emphysema evaluation versus perfusion scans, and you finally also get an idea about emphysema in MR. And this is maybe what we can expect from the near future. Talking about lung vasculature, this is experimental work. This is a 3D acquisition, and we can see that we can, without any contrast material, this is non-contrast enhanced, get an excellent visualization of the central pulmonary vessels. For example, or like you can hear on the single image on the left, we could nicely distinguish how the vessels and, of course, do any measurement that we want. So, but this is not yet ready, so we stick with what we have, and we, of course, we look on lung function. Because we say MR is the technique that ideally combines functional and morphologic imaging, as we claim. So our workhorse in this case is again the first pass perfusion. 3D data sets acquired within less than 2 seconds of acquisition time, one after another, fast time-resolved 3D gradient echo imaging for first pass perfusion imaging. This is the one that we have, which is easiest to implement if you start working on this. And there has been beautiful work from Yoshi Ono's group in Japan, and they sort of evaluated this and, of course, worked it up with color maps and a dedicated software. And you can, of course, generate time to peak, pulmonary blood flow, and pulmonary blood volume calculations from the gadolinium signal. We'll see that this is not so easy, and of course, you can also calculate a mean transit time by just dividing these through 2 values. So this would be a healthy subject, beautiful homogeneous charts in homogeneous colors. And this is what you would find in a pulmonary arterial hypertension patient. It gets much more inhomogeneous, and of course you get lower values. So in this work they had the mean pulmonary arterial pressure against the pulmonary blood flow, and it decreased continuously. So the higher the mean pulmonary arterial pressure was, the lower the pulmonary blood flow was, inversely correlated, and mean transit time increased with pulmonary arterial pressure. So this is what you find, and we will find in the literature. PAH patients, so we're talking about the idiopathics right now, have a slower pulmonary blood flow and a longer mean transit time, and this correlates with pulmonary vascular resistance and the mean pulmonary arterial pressure. In the same year, we will also find literature. They were a bit more cautious on this. Sebastian Ley and his group, he found out that in particular the dorsal, the posterior mean transit times, meaning there's the best perfusion, there you have, the measurement is the easiest. There they said, well, this differs in pulmonary hypertension, in that case, pulmonary hypertension in general, from normals, but not in the other parts of the lung. So there's a little bit weakness in this data. Is this maybe a good test for assessment of disease severity? Well, we may have looked at a certain problem that we come across when we start using this for quantitative imaging. It's the nonlinearity of gadolinium concentration and signal. This is the biggest point, and the smaller point is as well. We are looking on the serum, because the gadolinium is basically in the serum of the blood, and there's experimental data showing that hematocrit serum ratio in the lung may differ from the peripheral values. Well, this is maybe just a few percent, but the big problem is the linearity. If you take a certain amount of gadolinium contrast agent, dilute it in water and make a dilution series and put it in a CT scanner. As simple as that, because it also may work as a CT contrast agent, basically. So you see a linear increase in Hounsfield units with increased gadolinium contrast concentration. If you put the same dilution series into MR, you see this well-known curve, you see a saturation, and above a certain concentration, you lose the linear range. The important point is that in all these calculations, all these assumptions that are made to calculate these beautiful maps, you have an arterial input function, which is the rise of concentration in the pulmonary artery, and compare this to the periphery. So what they did in this group was a very smart idea. They said, well, are we, with which amount of gadolinium enhancement peripherally injected, are we in the arterial phase? So they simply injected MR contrast agent, but investigated the animals in a CT scanner, looking at the increase of density in the pulmonary artery, just to see is this linear or not. And already with a bolus as low as 0.05 millimole per kilogram, which is not much, 3 of 5 animals were not linear anymore. And if you take a 0.07, all are not linear anymore. So this poses the problem that, this nicely illuminates the problem that if you want to do exact quantification from these perfusion maps, there are still a number of open questions. However, the only way to go around with this is use very low contrast dose, as we've seen, to be very low. For example, this was again the group of Ono, and it's published in the same year. For a 70 kilogram subject, they suggested something in between 0.02 and 0.04. However, this is very few. You just see the lung lighting up in this series, but for visual examination, it's relatively low. It may be exact from a technical point of view, but it's difficult for visual assessment. Or you may use a dual bolus approach. Use a low dose to get the arterial input fraction and a high dose for the parenchyma perfusion. However, it is not that easy. Maybe things may facilitate during the next years to come, because this is probably the most promising technique that we have already, that we have so far. Just imagine measuring on a single point over the lung the signal. With very short image acquisition times, one after another, looking at it like a film and just measuring this, you will see, of course, with in and expiration of the lung, this will change the signal in a very low frequency curve. And you will, of course, see the effects of blood flow from cardiac action. So it will decrease in the systole when the blood is flowing rapidly, and when it slows down in diastole, it goes up. So we see the heart frequency and the perfusion. And from this, you can calculate from these image data by Fourier transformation. You can sort of extract the ventilation-related data and the perfusion-related data and come up with a ventilation and perfusion-weighted image of the lung. It looks like this if you use it in present. This was a study from this Gerger Baumann and his group. They had a patient with acute pulmonary embolism. We see the ventilation-weighted scanning and the perfusion-weighted scanning, and we very nicely see a ventilation-perfusion mismatch. And they controlled this patient later after recovery, and you see ventilation and perfusion are nicely restored. And the good thing about this is that all these images are acquired in free breathing. There's no ECG triggering needed. This is a relatively quick examination. So this is maybe the candidate for the future of lung perfusion imaging. Unfortunately, this is experimental work. It's now being sort of in a preclinical evaluation phase, but this may still take a few years, but this is probably the technology to go on. Finally, we have to talk about what else could we see on our MR images of the lung. Definitely, we can again talk about pulmonary artery stiffness. If we take these phase contrast images, on a phase contrast measurement, we could, of course, look on the distensibility of the pulmonary artery, as well as we could do on any other. What is about this pulmonary artery stiffness? What does it really mean? It means that the artery gets filled and gets stiff, and the ventricle pushes the blood in and it flows back. So it sort of gets a kickback, a continuous kickback procedure. The oscillatory work of the right ventricle grows, and this makes it so difficult. So it was found in experimental work that this precedes the right ventricle performance changes. And you can calculate a lot of different indices from this. However, this was found to be an independent, non-invasive predictor of PAH mortality. So this is hard data you could generate from your images. You can look on 2D phase contrast flow measurements on the pulmonary artery, and you will find a number of indices like reduced pulmonary velocities. Time to peak velocity would be shorter because it's running against the heart wall. Velocity rise gradient is steeper, and you will find a reduced PA pulsatility at all. This is one of the fanciest work that is around. This is from a very ambitious group here in Austria, in Graz. They're using a 4D flow, a volumetric sampling of phase contrast information, and they are generating this view on how the pulmonary blood flow really distributes into the pulmonary artery. Just imagine a jet going into a large bag, so it would sort of produce some sort of a turbulence, and they found that this sort of a vortex, of a turbulence, and the longer it persists, the more severe pulmonary arterial pressure is. They saw this is a PH patient, this is a patient with latent PH, or we're starting with some very short vortex here, and this would be the normal flow. So the longer this vortex persists, this correlated to PA pressure at rest. So they evaluated different methods to look on this. So it's a fast developing, very, I must say, very complex technique still, but finally this is used for visualization, and it can be evaluated just by the eye from these images finally. So different ways to look on this, and these all correlated. So in a group of 50 patients, they compared this to right heart catheterization results, and it might be a very reliable, non-invasive, non-ionizing test for pH. However, not easy to use everywhere. So we have seen a lot of fancy work now. Now we have to look at what our MR scan delivers as well. Of course, we have the heart on the MR scan, and this is the strength of the MR. We can definitely see all the primary signs of right ventricular stain. We can look on scene images. We can see the dyskinesia of the right ventricular free wall, called McConnell's sign. This is a name from echocardiography, but of course we see it on MR as well. Straightening of the interventricular septum, bowing of the interventricular septum to the left ventricle. Typically, if you have a elevated right ventricular pressure over 67 millimeters hydrogenium. So this is what we see. We see the enlarged right ventricle. We see the thickened wall of hypertrophy. We see the dilated right atrium, and we see the right ventricular septum curve towards the left ventricle. Again, already we see a jet in the pulmonary valve due to the very high, very elevated pulmonary pressure. So we see all these secondary signs of right ventricular stain, which is progressive right ventricular hypertrophy, dilatation, jets over the valves, and occasionally, not that seldomly, we see this pericardial effusion. Like in this patient, you see how this, in diastole and in systole, how this right ventricle sort of bulges around the volume that it can throw out, and sort of you see the left ventricle moving over. And we can look at these beautiful images from the literature where we see in systole a jet over the pulmonary valve, and another example of a beautiful jet over the tricuspid valve. Finally, we have contrast enhancement, and this relates to the last question that we had after the last talk. This is the delayed contrast enhancement at the septal insertions of the myocardium. Well, this appears a few minutes after the acquisition, and this is probably the explanation and the answer to that question, that we would usually not scan a few minutes later on CT again to see this, but I'm not sure if we would have probably a chance to see that, in particular with dual energy CT. Could be probable. But however, in MR we have the time anyhow, so we can wait a few minutes and then see this. It's very common in elevated pulmonary arterial pressure, and it's determinant and the severity of pulmonary arterial pressure correlates with this. So if we look on the right ventricular insertion point late enhancement, we see from this beautiful work from 2 years ago, we see that once it occurs, it predicts an adverse outcome. It means that the right ventricular has a definite problem, and it also correlates with the right ventricular ejection fraction. This is probably the most important parameter because this is directly the function of the right ventricle. So we are already again at function, and of course you can do all these functional measurements on the short axis ECG-dated images. You can calculate a number of different indices. You are definitely familiar with most of these. So among them, there's the 2D phase contrast MR, where you could have a look on the amount of valvular regurgitation to sort of measure the effect of the functional problems. And among all these numbers, these are probably the most relevant for prognosis, and these can be derived relatively rapidly by this evaluation, which has become, with the preformation, with the more advanced reformatting tools and the advanced workstations, has become quite easy. It used to be very tedious a few years ago, but it has become quite comfortable to acquire these parameters. So the right ventricular function, the improvement in right ventricular ejection function is correlated with survival as a sign of treatment, prognosis and treatment. If we have right ventricular ejection function going down and pulmonary arterial pressure going up, in other work, they found this definitely as a sign of poor prognosis. And this improves also after successful thromboembolic aneurysm. endarterectomy, as we have seen in the CTPA patient. So this is the definitely value that we would measure. So the mini protocol for MR in that case for a complete evaluation would be senior SSFP images in the short axis, basically, and also some axials, short axis, and some 4-chamber views as well, and the gadolinium late enhancement. So if we look on chronic thromboembolic pulmonary hypertension, we can, of course, look for the same signs as we've seen for the CT before. We can see the adherent thrombotic material. We see the corkscrewing of the vessels. We see some webs. We have here the comparison of PAH versus CTPH. This is CTPH. We see the webs. We see these bulging vessels, and there we see the pulmonary arterial hypertension patient with a much different image. And these images from the literature, again, this is CTPH. We see the thrombotic material and the pruning of the peripheral vessels, and we see the much smoother appearance here in the PAH. An important point in chronic thromboembolic pulmonary hypertension is to have a look again at the bronchial arteries. We have seen that before, because this is, in some work, related to a good prognosis after surgery if there's a large proportion of systemic circulation contributing. The important point, if you use the EMR for this, it could be difficult to see these on the subtracted arteriograms. So using non-contrast enhanced SSFP MRI is an important point in this CTPH evaluation, or in any protocol evaluating PH, so that you would also find CTPH. So this is the thrombus that can be nicely seen. We would see it in the perfusion images. We have had that before. We would not need any VQ scanning because we have it here. This is the wedge-shaped defects, and this is a slightly inhomogeneous perfusion in pulmonary arterial hypertension, so CTPH wedge shape, the other slightly inhomogeneous. And we can, of course, produce beautiful, colorful maps from this, from the perfusion defects or the compared to a normal subject here in this case. But again, the important point is including these non-contrast enhanced images as well. They facilitate much detection of the central large thrombi. So, thoracic MRI and PAH is the best image providing morphological and functional information on heart and lung without extra radiation, definitely. You can use it to track parameters correlated to survival. As you've seen, the stiffness of the PA and the right ventricular function, you can measure it directly, and is probably the most comprehensive and effective single examination for diagnosis and follow-up. How to do it? I may not leave you without a recipe. So among the sequences that we have had, first-time evaluation. Patient comes with suspected pulmonary hypertension. Nobody knows from what, so we do a full examination package. I say we can invest 25 minutes in that. So we have the fast T2 weighted images. We have these steady-state gradient echo or SSFP images. Then, of course, a first-pass perfusion, replacing our VQ angiogram. We have an MRA, and, of course, the additional recirculation phase images. Just in case that our angiogram does not work out nicely, we have this for backup. On the heart side, I can say we can be very rude and reduce it to these two parts. We can use a steady-state gradient echo imaging in axials and 4-chamber views. In breath hold, ECG triggered, should not take much more than 5 minutes. And of course, after we have done all the lung stuff, again, we can have a second look on the heart doing the late enhancements, not losing any time. So the full package would be 25 minutes for evaluation of unclear patients. Anyhow, you may argue, well, 25 minutes is quite a bit. Do we really need all this? Of course not. If we already know a lot about a patient, if we want to judge the severity of disease and get information about prognosis, we can, of course, omit those. We can, of course, let away the contrast-enhanced images, and we're leaving with a protocol which is less than 50-minute room time, and this makes it also a very fast and very exactive examination, not producing only an overview of what is up with the patient, also giving us an idea about the severity of the disease and important prognostic information. And I think less than 50 minutes room time is still affordable. Thank you very much for your attention.